Hello, everyone. A very warm welcome to you all. Thank you for joining this evening for what I'm sure will be a fascinating Medicine for Members event. Big welcome to all our CUH members and also to members of the public who are joining us. For those of you who are not members, you can join us. You can visit our website, www.chuh.nhs.uk, and you'll get alerts to events such as this. My name is Adele White, and I'm on the Board of Governors here at Addenbrooke's, and it's my great pleasure to host this Medicine for Members event. And I'm really pleased we've continued to run these events throughout the pandemic. So I'm going to introduce this session tonight and introduce the speakers. So irritable bowel syndrome, IBS, is a very, very common condition. We estimate that around 1 in 10 people suffer from IBS at some point in their lives worldwide. And symptoms of this very debilitating, distressing condition include such things as abdominal pain, bloating, bowel dysfunction. So the new research here at Addenbrooke's looks at the origins of IBS in the brain, and we're going to hear more about that and the fascinating link between brain and gut health this evening, and that's something I'm particularly interested in. And causes of IBS are not really well understood, but certainly, the latest research leads us to hope that new treatments will result. And we're also going to touch this evening on the connection between anxiety and IBS, and we're going to hear some first-hand accounts of that. So this evening, we've got two very well qualified speakers for you. Professor Miles Parks, who's consultant gastroenterologist here at Addenbrooke's. Miles has been a consultant here for over 20 years, and he has research interests in the use of genome-wide genetic analysis to provide new insights into the origins of bowel diseases. And we also are very pleased to have Laura Teves with us. Laura is a patient here at Addenbrooke's. She's a professional lady, and she has suffered from IBS since recovering from COVID in 2021. And she's also suffered from anxiety and depression. And we give a big thanks to Laura for agreeing to share her very personal experiences of this condition with us. We're going to hear from our two speakers first. I'm really hoping you've got some questions for us. We've got attendees who are attending on Zoom, and those on Zoom, could you please use the Q&A box to put your questions in, and we'll pick those up there. For those of you who are joining on Facebook, could I please ask you to insert your questions in the comments box, and we'll pick them up during the presentations. So without further ado, I'm first of all going to hand you over to Laura, who's going to tell us about her experiences. Thank you, Laura.
Thanks very much, Adele.
So the way we thought we might do this, Laura, sorry to butt in, is just to provide a bit of framework. I'm going to run this a little bit like I would do a normal consultation in my outpatient clinic, if that's okay with Laura. But just to run through the sorts of symptoms that you were getting, Laura, and how we ended up sort of dealing with those and managing things as we went along. And then I'm going to sort of feed into a short presentation. I'm not going to go on too long about genetics. It's that time of day when you can't have too much genetics. And then we'll take some questions and answers if that's all right. So Laura, just remind me, what symptoms was it that took you to your doctor and ended up being referred to me in the end? What were the main symptoms you were getting at that time?
So I was really struggling with a lot of lethargic feelings. I had awful kind of bloating, especially after eating. I was struggling with severe constipation and then moments of kind of unexpected diarrhea. And it was becoming increasingly frequent, so especially after I ate. And it got to the point where I was really struggling to do normal activities. So I spoke to the doctor and they asked me if I would like to be referred, and that's.
So what sort of things did it stop you doing, in fact? Did it stop you going out of the house? Did it stop you eating? Or what were the things that you found most limited?
Yeah, it got to a point where I actually couldn't really go out the house. Obviously we were during kind of lockdown anyway,
right.
But I was really struggling to just kind of go out for a walk, normal daily activities. Sometimes even getting out of bed was just pure agony. I was constantly bloated, and just sitting with company, I was often embarrassed where I'd have to just run off to the toilet, things like that. So it was not just physical, but it was also kind of mental kind of environments as well.
And so trying to hold down a sort of regular job, obviously setting aside lockdown and working from home, would have been tricky for you, right? Business meetings or meeting clients or what have you.
Yeah, I mean, fortunately, I'm really lucky. My team are very supportive, but there have been times when I've had to kind of put myself on mute or, you know, kind of cancel a meeting and say, I'm really sorry, but I can't make this. And it started to impact my daily life.
Yeah. And just tell us, how long had you had those symptoms for at the point that you came to see us in the clinic? Had you always had those symptoms, or had there been other periods in your life when you'd had symptoms like this, or not really?
No, not really. I mean, obviously I'd suffered with, you know, general kind of stomach upsets over the years, but this was going on a lot longer than I'd kind of expected. I probably was suffering for about a good 3 to 6 months, I think, was the general duration that I expected it to pass. And then I went to the doctors, and then by the time I came to see you in clinic, I think it was about 6 months in total.
Yeah. And as I remember you saying that you'd had some COVID infection, you picked up a COVID infection, you felt that that had played some role in triggering off your symptoms. Was that right?
Yeah, definitely. So I had COVID over New Year of 2021. So yeah, Christmas 2020, and then I recovered quite early into January. And then from then on, that's when my symptoms seemed to kind of heighten.
Yeah, yeah, okay. And without divulging any medical confidences, tell us a little bit. I mean, I know you've been troubled by symptoms of anxiety over the years intermittently. Yeah. Tell us a little bit about that, if you don't mind.
No, not a problem. Yeah, of course, not a problem. So I was diagnosed with anxiety and depression when I was 23. Obviously, anybody that suffers knows that it kind of comes and goes in peaks and troughs. And because of lockdown, I was impacted quite dramatically with my anxiety. And that has played a huge part in, you know, dealing with IBS as well. Panic, frustration, struggles, you know, uncontrollable worry that you get with anxiety has made struggling with IBS a lot worse. Yeah,
okay. And tell us a little bit about the tiredness as well. That was a feature for you also, is that right? Did the tiredness get worse with your tummy symptoms?
Yeah. So the more bloated I felt, the more lethargic I felt, and really unable to go to the gym, go for a walk, etc. I used to go to the gym 3 to 5 times a week. And I felt like I was unable to do that at all.
Yeah. And did you know much about IBS at the point that you came to see me in the clinic? Had you heard much about that or knew about it or not really?
I had heard about it. Obviously, everybody's is kind of one of those subjects that you don't really want to talk about because it's too taboo. And I think that's something that I never expected to have IBS. I just thought it was, you know, maybe a virus or something, but it was obviously something more than that when the longer it went on. So I didn't expect to suffer from it. Yeah.
I mean, it's true to say that a lot of people, perhaps less so for you because your symptoms were, I know they went on quite a long time, but for people who have had it for years and years, they often find that that they almost get dismissed by their GPs or their doctors because, you know, back here they are back again, same old symptoms. Don't they know there's nothing really the matter with them and so on and so forth. Yeah. Hopefully that hadn't been your experience, had it?
Unfortunately, yes, actually it was.
Oh, sorry for that.
That's okay. I mean,
not by me, I hope.
No, definitely not. And actually, you were one of the first people that really listened and really kind of reassured me to say, you know, this is something that happens to so many people and not just you'll be fine. You know, it's an awful disease, and it's something that hinders so many people. And I think it's really crucial that people kind of become more aware of it and also feel less embarrassed. You know, so many people suffer that actually, if you just are open about it, a lot of people are kind of, oh God, me too, that kind of thing.
Yeah, it is. It's very like that. And I'm afraid the medical profession is a bit dismissive of this condition, but I think you've nicely illustrated to us how, you know, how impactful it can be on normal life and your ability to live a normal life, actually, which is a problem. And then just remind us, what tests did you have for your diagnosis, and then what treatments most helped you, would you say?
So you did a physical examination of my abdomen, asked me obviously the general questions. You ran some blood tests to make sure that, I was completely, there wasn't any kind of other factors. And everything came back normal, and you asked me obviously kind of questions, and that's when you said that it was post-infection related, which can often happen. I remember you saying. The treatment that we discussed was exercise, regular exercise, just regardless of whether I felt like it or not, going out for a walk, running, which
it's brutal in the Parks Clinic, right? You don't get any rest here.
Definitely, doing the exercise, going out, making sure that I'm active, but also things that have helped me as well as flaxseed. So I know it sounds a very simple thing, but that is to this day the thing that I count as being a godsend for me. It has turned my life around, and it's just something that's so simple but can help so much.
It's crazy, isn't it? But just for anybody who wants to write this down, powdered flaxseed or powdered linseed, it's the same stuff. The Americans tend to call it flaxseed and the Brits tend to call it linseed, but it's interchangeable. You can buy it at the supermarket or Holland & Barrett, and it's the powdered stuff, not the whole seeds that you want. But it really works like magic on bowels that have gone a bit wonky. And Laura, it was great to hear that your symptoms settled on these relatively straightforward adjustments, but which work often, and they often do actually, which is great. All right, listen, I'm mindful that the clock is marching on, and Adele's going to get cross at us if we overrun, so we mustn't do that. Do you mind if I just whiz through my presentation, and then we'll come back to the questions, but perhaps if Laura and I can both take the questions at the end, that would be great.
Absolutely fine, go ahead.
Great. Now then, I'm going to try and screen share. Let me just do this. And I apologize a little bit about this presentation, which is slightly blagged off one of my trainees who gave this presentation on my behalf at the Grand Round. So it's a little bit medical, but I'm going to just skip over any of the stuff that's medical. Let me just, from the beginning. Can you see that? And is it occupying the whole screen? Okay. All right. So there is this question out there about irritable bowel. One of the concerns that people and patients have is that they're being dismissed as being you're just anxious, and that's all it is, which is doing everybody a disservice actually. Dismissing anxiety is not the right approach to anxiety management, and the link between anxiety and brain and gut is the understanding of that link is evolving. It's absolutely true to say. And I always point out to people that nobody who's ever sat outside a job interview doesn't know there's a really good connection between your brain and your gut. It's true, and we just don't understand why, and we should be honest about that. So I'm going to briefly skip through some of our sort of diagnostic maneuvers that we do for IBS, and then I'm going to briefly talk to you about a genetic study that we ran recently. So you've heard already about the sorts of symptoms that people with IBS get, characteristically tummy pain, bloating, and altered bowel function. The tiredness that Laura describes is absolutely typical, and I would say that there are a bunch of other symptoms associated as well. It is really common. 10 to 15% of the global population. It's not just a disease or an illness of Western society. Usually presents in early adult life, but actually children can get it and old people can get it as well. It's more common in women, and as Laura has indicated, the symptoms can be brutal, all right? And it's not something that it's fair to dismiss as being just one of those things. It accounts for more than 50% of the referrals into our clinic, and so the hospital and the managers pay attention to this because it's quite an expensive condition, actually, for the NHS to have to manage. We try and diagnose it really just on symptoms, and I've described to you the symptoms already. And if somebody's giving us a very typical history of IBS, then oftentimes there's not much need to go too much further beyond that. There are these slightly distinctive patterns, the constipation predominant version, the diarrhea predominant version, or the commonest type is where actually there's a very rapid alternation in bowel function between constipation and diarrhea, going backwards and forwards on those two things. Stress often makes it worse, and oftentimes people do report having been diagnosed with some of these other conditions, things like fibromyalgia, chronic fatigue, and anxiety and depression. These are all very common associations with IBS symptoms. And actually, interestingly, the order in which these things happens is not consistent. So people with anxiety are more prone to developing IBS symptoms, but actually it also works the other way around. Some people with IBS symptoms later present with symptoms of anxiety. And so there is some understanding that these things are somehow causally connected, but without real understanding as to how so. And we, as doctors, tend to, when they don't quite know what's going on, they wave their hands around and talk about the environment and genes, various other things. And so we do with IBS as well, recognizing that there is this big brain-gut connection. Importantly, and this is a point we make to our trainees, is that IBS is not a diagnosis of exclusion. And it does have a bit of a reputation for that physicians and doctors who are a bit less experienced in management of IBS, people come along with these dreadful symptoms. Doctors want to help people. They're worried that they might miss a serious diagnosis, Crohn's disease or something like that, or cancer even in some situations. And often partly because the patients in front of them are quite anxious about stuff, everybody feels the need to do CT scans and endoscopies and colonoscopies. And this is not a great way to manage IBS, actually, it turns out. Firstly, people with IBS don't like having those tests. Who knew that people don't like having colonoscopy or endoscopy? And secondly, actually, it's not necessary. The symptom pattern is very typical. And so I encourage our trainees and juniors to try and, when you recognize IBS, make that diagnosis confidently. Just do some relatively straightforward tests, but don't then launch off into a tirade of CT scans and colonoscopies and stuff. There are a load of conflicting advice out there about how to manage IBS, and it's really problematic, I'm afraid. Often, these sorts of things get wheeled out. Try and find a way to relax. I think that's such an unhelpful statement on many levels. Why don't you just relax, but at baseline, it's probably true. But I think people need to be helped to find ways to relax. And, I often spend time encouraging people to prioritize things that they enjoy doing in their life. Life is busy, and oftentimes, talking to people who are juggling 3 children and a full-time career and hour-and-a-half commute and so on and so forth. And I said, no wonder you've got IBS. You need to find a way of just taking some time out for yourself, and whether that's exercise or even if it's going down to the pub and having a chat with your mates or whatever it is, but building those things into the daily routine can be important. And then there's some don'ts down there as well. One of the funny things or odd things about IBS is that often the really healthy foods are things that can make it worse, not better. And that causes confusion and some problems. So actually reducing the amount of fiber in the diet is often a thing that we do, but not powdered flaxseed, which is a rather refined type of fiber, causes much, much less trouble to people's tummies than, broccoli or cauliflower, for example. Wheat and dairy and those things, they sometimes cause problems. The drug treatments in IBS, they're not brilliant. They work in some people. And interestingly, we know for a fact that the most effective drug treatment in IBS is some stuff called Amitriptyline, which in the old days used to be used as an antidepressant. And there's some good explanations for why that's the case, but a lot of the chemicals that control signaling and neurotransmission, so control and regulate mood in the brain, they're the same chemicals that regulate pain signaling in your tummy. And of course, when you take a medication, you're just modulating or regulating the levels of these things. And so that's really why it works, I think, in IBS. It probably has some effect on mood as well, but it significantly affects the tummy also. I'm going to very briefly skip you through this genetic study that we did. It's a bit technical, and I apologize about that. So I'm just going to really stick to the principles. We use this technique of genome-wide association scanning. What does that mean? It means that you can consider the whole genome all at once and look for areas in the genome which are linked to any given condition by comparing large groups of people who have got the condition you're interested in to large groups of people who don't have that condition, who are so-called controls. And this technology has been around for quite a long time now. We ran our study mostly out of the biobank, which is an amazing resource of data and clinical information and genetics data as well. 500,000 people are in the UK biobank. We developed a questionnaire to specifically ask people about symptoms, tummy symptoms, IBS symptoms, as well as their previous diagnosis of IBS. And These were just the criteria that we used. Don't need to dwell on those. We had responses from 170,000 people, which I was impressed by. That's quite a lot of people responding to a questionnaire. Felt a bit humbled by that, actually. I've never done a research study where 170,000 people responded. And interestingly, looking across the whole cohort, nearly 20% of people reported symptoms that measured up for a diagnosis of IBS across this big cohort. There are some biases in here. Two-thirds, so just over two-thirds were female with the symptoms. And actually, even at this particular moment, 14% of people had symptoms that were enough for a diagnosis of IBS. Don't need to dwell on this. But this diagram makes the point that there are quite a lot of other symptoms not connected to your tummy, but which are quite common in IBS. So things like headaches and back pain are also quite common. Sleep disturbance, the tiredness side of things is pulled out here. And this diagram makes the point that the more severe your IBS symptoms, the more severe your anxiety symptoms as well, across the whole cohort. And we lined up and asked people about their symptoms of anxiety to help us to construct this. Family history was quite common, and people quite frequently reported a history of anxiety, depression, more commonly those people who had IBS symptoms than people who didn't. This is the results of the genetics analysis. I'm not going to go into the detail of this, but actually half a dozen areas of the genome lit up and told us that they were implicated as containing genes likely to be relevant to the causation of IBS. And some of the things that were quite interesting about this, a number of these signals had previously been seen in anxiety and depression, actually, which was interesting. And also interesting is that looking at them at face value, they were much more implicated as being brain genes rather than gut genes. Now, you can formalize that by doing these types of analysis, which tell you where these different genes are expressed in the body. And I'm not sure whether you can see my arrow, but can you see my arrow? Yeah, you can. Okay. So over this part, which represents the brain, you can see it's a bit darker green. And that tells you that there's a sort of predominance of these genes being expressed over what actually is a brain expressed part, with relatively less expression over the gut expression end of things. So these genetic signals seem to be regulating genes which are mostly expressed in the brain and the nervous system, and not so much actually in the gut, although the gut itself, of course, contains a lot of nerves. And when actually you just ask the question that, looking all the way across the genome, what does IBS look most like? And you take a list which has got several hundred conditions on it, all of their own genome-wide signals and signatures. Actually, the conditions which line up, the top 4 conditions were anxiety, neuroticism, depression, and insomnia. And so the genetics of IBS looks very similar to the genetics of these conditions. And it tells us, and actually through various other clever genetic techniques, not done by me, but done by our statisticians, we were able to show that these conditions are coming from the same place. It's not that anxiety is causing IBS or tummy symptoms. It's that these have a shared genetic heritage, if you like, and that the same genetic variants that increase your risk of developing anxiety are the same ones that increase your risk of developing IBS. So I've trotted through and we've spoken a bit about some of the symptoms of IBS and some of the treatments that we can bring to bear. And we've discussed also some of these genetic evidence for the overlap between anxiety and depression and IBS type symptoms. And it begins to shed a light on some of the things that we've understood for a while, particularly that some of the psychological approaches, some of the behavioral treatments like CBT, which you'll have heard of, cognitive behavioral therapy, and hypnotherapy, actually, these are actually quite well established as treatments for IBS, but nobody's ever really understood why they work very well before. But now we're beginning to get some understandings as to why that might be the case. And it does give us, I think, a bit more justification, if you like, for promoting these as useful treatment strategies for people who've got difficult to manage IBS symptoms. Now, thankfully, Laura's symptoms responded nicely to, the combination of exercise and modifying her diet and adding in the powdered flaxseed. But there are elements of that, the process of setting routines and getting out and exercising and so on and so forth. We all benefit from that. And actually, for many of us, we rely on that to help us to relax, getting, sleep patterns under control, and so on and so forth. So yeah, there are elements of that here as well. So I'm going to wrap there. I hope that's been of some interest. Let me stop showing my screen, and then we can all see each other again. I'm happy to take any questions.
Thank you very much indeed, Laura and Miles. That's amazing to hear all of that. So we are genetically predisposed, it would seem. If I could, I'd just put the first question. We've got some questions in the Q&A box, which I'm going to start to go through. Laura, just to come back to you, how long did this process for you take? What, from sort of coming to see Miles, what was the sort of timeline for you? And I suppose that's still going on, isn't it, in terms of when you started to feel better?
Yeah, so the timeline was probably in total from initial kind of onset, which was the beginning of January 2021, to seeing Miles was about 6 months, and then to start getting into a good routine and seeing effective results. It wasn't immediate, it wasn't overnight, but it was within a couple of weeks. I started to see a lot of changes within a couple of weeks, as long as I was consistent. Yeah, so that was the real kind of time frame that I was looking at. And obviously I still suffer with it. It doesn't just go away overnight, but I know the managing, coping strategies now.
Yeah, sure. All right. Well, thank you.
So I think that's a really important point that Laura makes. Your gut is a bit like a super tanker, and it doesn't tend to respond terribly quickly. And particularly these sorts of symptoms, they do take a week or two to respond to any particular intervention. So for people who are experiencing these symptoms, don't chop and change stuff too quickly. Give any change that you've made a bit of a time, a week or two typically, before you sort of give up and move on to the next one. Because if you chop and change too quickly, you never really properly bottom out what works and what doesn't.
Yeah, great. So I'm going to just come to some of the questions we've had coming in on the Q&A box here. So we've got a question here about getting help for treatment for someone who's on the autistic spectrum and extreme anxiety causing lots of stress. And a question really where someone can get help for that. It's been going on for 3 years.
Yeah, these things are tricky, and again, you see the correlation with the anxiety coming out here. I mean, some of the things that we've outlined here today, those may help your daughter, I would hope. The routines, powdered flaxseed of bowel function is a bit wonky. Exercise is great, and I think Laura alluded to the fact that often when you're feeling really rubbish and tired, the last thing you want to go and do is to go and do some exercise. But people often report that having done it, they feel so much better. And you sort of almost have to physically push yourself out the door to go and do it. Laura, do you want to say anything about that?
Yeah, the amount of times I've just wanted to go back up into bed, but I've physically pushed myself out the door to actually go and do the exercise that I need to do. It's been, yeah, the answer that I needed that day. That was definitely the case.
And it's good for people who are tired. Exercise does often help people who are feeling tired. I know it's a bit controversial whether that's the case, but anecdotally among a large group of people and patients, that definitely is the case. And exercise is also good for gut function. And one of the things I sometimes ask my patients is, have you got a dog? And if they say yes, I always say, what's the first thing your dog does when you take it for a walk? And I won't continue that conversation, but it's people who've got a dog will know what I'm talking about. And it turns out that actually exercise is good for human gut function, same as it is for your dog's gut function, actually.
Actually, Miles, I just want to touch on that as well, that people that suffer with anxiety as well, exercise really helps anxiety. Yes. So it's kind of a twofold there as well.
I totally agree with that. And it's partly the routine of it, and it's partly just the headspace sort of side of things. My daughter suffers with anxiety, and she totally relies on running to manage her anxiety, and it really helps her, actually.
And Laura, what about you? What forms of exercise did you find most beneficial?
So I actually weightlift. So I continue, like Miles suggested, just to continue doing that as well. But I also do cardio in terms of I go for a walk. I occasionally run, but I generally try the treadmill. Sorry, not the treadmill, the cross trainer. That is the thing that works for me the most, because I've got a previous knee injury, but that's the cross trainer is the best thing for me, because it's still the jiggling motion, but it's not so much impact on my knee.
Yeah, and something that people enjoy doing is good, you know, of course.
And is cardio important, Miles, would you say?
I don't think it's necessarily important. Sometimes just going for a walk is fine, to be honest with you. You know, it's part of that just process of getting out in fresh air and headspace as much as anything else, I think. So, but I think if you can add in a bit of exercise on top, then I think that's good.
Mm-hmm. Coming back to the questions we've got coming in. So we've got one on dietary intolerances. So what sort of link is there with patients who've got dietary intolerances with symptoms? Yeah,
thank you. Fiona, I think it is, who's asked that question. There's a huge overlap between dietary intolerances and IBS type symptoms. And exactly why that's the case, I think is difficult to understand. Often when stress levels are up and people are prone to IBS, they may need to be quite tight on their diet. And when stress levels are down, people on holidays, they may find that they can now eat stuff that they had to stop when they were in the stressful phase. So these things are a bit of they're not absolute intolerances often for people in this situation. And normally if people have had to cut out wheat or dairy or whatever it is, I normally suggest to them every 6 months or so, they just try themselves back with a little bit of it and just see whether they can now tolerate it. Because oftentimes these things do come and go a bit over time. And, after all, life is for living, and maintaining interest in your diet is an important part of this. So not ending up, and again, one of the points I make to people is, if you're going to try cutting out a big food group like, I don't know, wheat, say, for the sake of argument, you need to feel a lot better cutting out wheat, feel 80% better to make that something to stay off. Don't just feel 5% better cutting out wheat and then move on to dairy and feel 5% better, because you'll just end up eating rice cakes and nothing else. And that's not a way to be. So you have to be a bit measured about this. And we do sometimes ask our dietitians, and actually in the community, your GP can refer you to a community dietitian for advice about dietary management of IBS. So that's something worth knowing as well. You don't have to come through the hospital for that. And as I mentioned before, there are some relatively more common diet triggers for this. Brassica vegetables, cauliflower, broccoli, sprouts, cabbage is in one group. Pulses, chickpeas, lentils, baked beans, of course, other stuff. Those sometimes make the bloating a lot worse. Onions and garlics and peppers and stuff like that's another common group. Wheat we already mentioned. So these are the relatively common things. And an important thing to mention is there's no really good tests for dietary intolerances. The only way to tease these things out really is to cut them out one at a time, the groups of foods one at a time, and assess yourself after a week or two to see whether you're a lot better or not. I know the back of the Sunday Times will advertise the York test for 500 quid. I've got to tell you, spend 500 quid and go on holiday. Don't hand it to the people who run the York test. They will tell you that you're allergic to wheat, dairy, fiber, yeast. You don't need to spend 500 quid. I can give you the list of things they'll tell you that you're allergic to. And of course, those are all the things that are common as reasons for why people get intolerant. So people do the test, they cut those things out and they feel better. And then the York test is great.
Thank you. And I think you said something in your slides about processed foods, didn't you? Because we always hear that heavy processed foods are bad for us and fresh foods are better for us. Is the same apply with IBS, would you say?
Yeah, I'd be interested to hear Laura's thoughts about this. Sometimes people find that junk food is actually slightly easier to digest than really healthy stuff. So I don't know that I would be too dogmatic. Laura, what do you think?
So I struggle with certain things and I know which triggers me off. So really heavy, greasy foods, like
that's common.
The fish and chips out of the fish and chip shop. I can eat the chips, I can't eat the batter, and things like that. So it's really kind of dependent on what works for you. I really struggle with dairy, so I avoid heavy cream and things like that. So curries and things like that. But I can eat other things. So it's very much working out what you can work with. Like I can eat a pizza if it's made with real mozzarella rather than processed cheeses and things like that. It really does work what works for you. But one of the things about the diet was that Miles suggested to just eat a normal diet, and I was guilty of restricting everything because I thought that would be what was best for me. And actually when I cut out a specific food group like dairy, or actually one of the things that really affected me was cauliflower. And I cut it out, although I love it, was one of my bloating symptoms. So yeah, it's sometimes just one specific thing that really can cause so much problem.
Yeah, it's funny, isn't it? Yeah.
Okay, good. Now, just going back to the issue of genes and genetic disposition. We've got a question here about IBS and bipolar. Is there a genetic, same genetic?
Yeah, bipolar's in that mix of psychological and neuro conditions that are absolutely linked. Yeah, for sure.
Okay, good. And we've also got a question here around lactose intolerance and around a diagnosis of celiac disease.
Yes, I can see that question from Paul. It is really confusing, and you know, bear in mind that 15% of the population have got IBS, and so of course 15% of people with celiac disease will also have IBS, and it's always really, really tricky if you've got two separate conditions where the symptoms can overlap quite a lot. Oftentimes people with celiac don't have many tummy symptoms, actually. Sometimes they do, but not always. And so I suspect if you've been very careful with your diet and cut out the gluten, and you're still getting a lot of troublesome, and lactose, and you make that point, people who have celiac disease are often lactose intolerant as well. But if you're being very careful with those things and you're still getting tummy symptoms, then it probably is worth just looking at gently at some other dietary type things and exploring about possible IBS things. You can get some blood tests as well, just to make sure your celiac disease is properly under control and there isn't any gluten sneaking in there and just continuing to cause problems, which does sometimes happen.
I'm also going to back to this issue. I think you mentioned about trying probiotics. We've got a question here about bowel microbiotes.
Yeah.
So
the question is, is there a change in the bugs that live inside your gut, and how do we sort of control or manipulate that to make things improve? There definitely is a link to the bugs that live inside us. And of course, what we eat significantly affects the bugs that live and thrive and survive inside of us. Probiotics probably do that a bit as well. I have to tell you that probiotics haven't been the sort of dramatic solution to IBS that perhaps one might have hoped early on. Like a lot of things in IBS, it's worth a go with them, but don't bankrupt yourself and don't keep taking them if they're not clearly helping. Give them a trial for a couple of weeks, the standard couple of weeks. But if you're not better after 2 weeks, don't keep going just because the advert on the telly says that they're good for you. Keep going if they're helping your symptoms, but not otherwise. And yes, the linseed probably does, the flaxseed probably does affect your microbiota, as do all foods. And you know, that's probably one of the ways in which it can help. It's a sort of rather fermentation resistant fiber, and you know, a lot of the brassica vegetables, cauliflower Laura mentioned, these are a real fuel to the bugs that live inside our colons, and the bugs that live inside us can grab those things like the residue of cauliflower, and they digest it by fermenting it. And anybody who remembers chemistry GCSE or O level knows that one of the products of fermentation is gas, and of course that's partly why those foods that provoke fermentation also increase gas production inside, and that's partly what contributes to the bloating in the symptoms. So cutting out the fuel supply for those bugs gets rid of some of that fermentation. The flaxseed is much less prone to that fermentation process, but it still keeps the bowel ticking along. Still got the fiber content, but it's in a rather fermentation resistant form.
And you mentioned powdered flaxseed, milled flaxseed.
Milled flaxseed, yeah.
In its natural form. Why is that? Is that just because it's easy to digest?
Yeah, if you eat powdered flaxseed, we don't digest them and they just come out the other end as, sorry, if you eat whole flax seeds, they just come out the other end as whole flax seeds, and they've failed to do what you want them to do. So they have to be smashed up for them to be able to produce the benefit that you really want.
Good, yeah.
I just wanted to add, Adele, and going on the topic of the flaxseed, a lot of people have always asked me, because I've spouted on about, you know, if you suffer from IBS, give flaxseed a try. And a lot of people say to me, how do you eat it? And that is kind of a struggle for some people, but I have it in oats, I have it in a smoothie, I have it with yogurt, I have it, you know, sometimes I have it in milk. And it's a bit weird, but you get kind of used to it. However you kind of feel that you can get it into your diet, sprinkle it on ice cream, however you feel that you can eat it, it's definitely worth trying to incorporate it in.
Yeah, bake with it. People want to end up on about a tablespoon once or twice a day, but to build up to that somewhat gradually. So it's quite a big dose. And as Laura said, identified, you have to work a bit hard to get that much into you. But people get used to it, and if it helps them, then often they find a way.
I put it in soup.
Yeah, put it in soup, bake with it, you know, lots of tricks of the trade, mixing up with your porridge, sprinkling it on your cornflakes, all those things, they all work.
Yeah. So we've got a question here about ethnicity and ethnic groups. Is there a particular genetic, because of the genetic component, have you seen that at all, Miles?
Yeah, we don't know the answer to that yet, and I'm afraid that's true of so many genetic studies that we do, is that they're often based on white European origin people, and a lot of the studies are just underpowered. They haven't got enough participants from non-white backgrounds in them, and I'm afraid that's true of the UK Biobank as well. So we don't know the answer to that, is the honest truth. I don't have any reason to suppose it'll be much different, and certainly in a clinical setting, you know, clinically IBS in white people and people from other ethnic backgrounds is identical. So I suspect the same principles will apply, to be honest with you. But yeah, the genetics data is a bit behind the curve on that.
And I've got to ask this question: why the predominance of women with this condition? Why do you think that is?
Yeah, we don't know the answer to that. We genuinely don't know the answer to that. And I don't think that anxiety is particularly more common in women than men. So I don't know. I don't know. But it's a very, you know, that's a universal finding from all of the studies that look at this issue.
We've got a question here about hypnotherapy. Laura, is that something that you considered ever or tried?
I haven't tried hypnotherapy, but I do have talking therapy. So I do visit a psychiatrist to deal with my anxiety. So I definitely would encourage that. I haven't, unfortunately, tried hypnotherapy, so I can't mention that one. But yes, talking therapy definitely helps me, 100%.
Yeah. Okay. And we've got someone here looking for advice on working in high stress environments. Someone's tried organic psyllium husk fiber capsules. I'm not familiar with that.
Yeah, I think, you know, working in high stress environments on the wards and elsewhere, you know, building in some things that you enjoy doing, I think helps people to ride the bumps. Making sure those things are prioritized in your working week, I think, is important. Making time for yourself so that you can, you know, the point I make to people is prioritize those things that you enjoy doing, and that's what allows you to then ride the bumps and the stress during the rest of the time. So it's not the first thing that gets cancelled because life is busy. It's actually the first thing in your diary, and nothing else moves to accommodate that. And I think that's good practice, actually, for people who are a bit prone to stress-related conditions.
Yes, yeah. And we've got a great question here coming in about, you know, should these seem like fairly straightforward interventions? Should we be managing these within primary care? We
totally should. The part of the issue, I think, is that, you know, although this is a very common condition and commonly presents in primary care, I think for people need to manage this condition confidently. And part of the problem is that oftentimes they'll meet a less experienced GP who will, you know, feel the need to do a colonoscopy and then a CT scan. And I think if you start off on the wrong track with the management of this condition, then it just stores up more and more problems, both for the health service, which can't afford it, but actually also for the poor patient on the receiving end of it as well. It's not a good way to manage it. I think, as we all know from our own experience of being patients, we like to be managed by people who are confident and know what they're doing, and they've met this before and they know how to deal with it. And some GPs are fantastic at that, but others of them are less good at this. And so this is why we continually get a significant workload. And this is universal around the world. It's not an NHSism. And of course, you know, in more financially driven healthcare systems, this drives a lot of money making as well. So that itself then stirs up its own set of problems. But, you know, even in the NHS, we definitely spend too much money investigating IBS. And I don't say that because we shouldn't spend money on IBS. I say that because actually it's not helpful. And if anything, it rather exacerbates the problem.
Yeah. And Laura, what was your experience of going to your GP? And that would have been during the worst of the pandemic, presumably, wouldn't it?
Yeah, unfortunately, I had to see a lot of GPs over the phone, and they asked me kind of a few questions. I actually got told to go to the hospital at one point because, you know, they thought that it was the most appropriate route of treatment, which isn't the case at all. And
the emergency department, you mean, Laura?
Yeah.
Oh, don't do that. I mean, this is just a disaster. Emergency departments are a disaster for people with this condition.
Yep, exactly. And one of the few people that actually put a stethoscope to my stomach was Miles. Nobody had considered that actually this was the situation, and that was a surprising reaction to me. You know, I would have thought that one of the few things that a GP would do is actually listen to whether my gut is either overactive or underactive, you know, kind of a basic treatment. But I don't know. As Miles said, it's sometimes you get a good one, sometimes you don't, and that's unfortunate. But
so, Miles, do you think the psychologist should be working alongside the gastroenterologist?
Absolutely, for sure. I mean, a lot of tummy problems do, you know, have a significant psychological component to them. And of course, there is no greater wealth of psychological support services than there is anything else in the NHS. So it is tricky. But I think knowing that CBT and those sorts of approaches can really help people with both the anxiety side of things. There's a question here about how do you manage the anxiety and how to help the IBS get better. I think a lot of those talking therapies can be really, really valuable for both of the conditions, actually. And I really encourage people to try and lock into those if they can. Is there any stuff online about this, Laura, do you know, or does anybody know?
I have looked, and there isn't that much, I don't think, about the link between it. I know obviously people think, oh, you know, oh, the anxiety causes my IBS, which is one of the things I remember you saying to me, that was something that you're keen for people to know, that that's not the case.
Yeah.
It impacts, and of course it does trigger it, like we've discussed, but there's not that much information out there. Not solid information, not other than just kind of a, you know, a newspaper article, really.
Yeah, it is tricky. There's a question here about daughter spending a long period on the loo, needs to feel comfortable she goes out, using lots of Buscopan. Don't worry about using lots of Buscopan. And, you know, and again, people find that they sometimes get told by the doctors, oh, we don't use as much of this. I just say, look, use stuff that works. And if you need to use a bigger dose, it's fine to do that. Don't feel bad about that. And if you need to stay on, you know, whether it's flaxseed or milk of magnesia or something else to keep your bowels ticking along, it's fine to do that. There's no evidence that those things cause problems, to be honest with you.
Laura, did you try the FODMAP diet? Did you have a look at that?
I did have a look into it, but it was something that I was a bit wary about. I work in the medical research industry anyway, so I'm quite able to kind of look at things and interpret things. And I wanted to speak to Miles before I considered that, and Miles actually referred me to a dietitian as part of my treatment, and we discussed the food groups, etc. So it wasn't specifically the FODMAP, but we looked at the fermentation side of the vegetables that I was eating and things. And that's something that I would definitely recommend, to go see a dietitian, because they can help you look at your daily diet and look at things that you may not think is an issue. Like, I would never have thought that broccoli and cauliflower to me would cause a problem, but actually there's a good scientific reason behind it.
Yeah. And we've got one question here around the kind of timeline. Did you find that, you know, your IBS symptoms kicked in pretty quickly after eating something that was a trigger? Yeah,
it can do. It can be within 10 minutes sometimes, if it's that bad. If I'm really, really stressed, it can literally be within minutes of me finishing my food, or sometimes even starting my food, because it's obviously that eating, you start your gut kind of moving anyway. Sometimes it can be half an hour, sometimes it can be longer. But if I'm having a flare up or I'm stressed, etc., then I can notice it very quickly. And you soon to learn the kind of triggers, I think, very quickly, that can help like diagnose things if you are doing that elimination of foods.
Sure. We've also got a question here, Miles, for you around hormones and hormone connection with IBS. One person suggested the only time that she's not suffered with IBS is during pregnancy.
So the hormones that regulate the menstrual cycle, and which are obviously affected by pregnancy as well, they do have an impact on what we call gut motility. So the way the bowel contracts and shuffle stuff through the system. And so some ladies do find that their tummy symptoms and their IBS symptoms are worse either perimenstrually, around the time of their periods, or mid-cycle. Often people get a bit constipated, particularly around those times. And so, yes, they are part of the story here, but I don't think it's the whole story as to why women are so much more frequently affected than men, but it's part of the story, probably.
Mm-hmm. Sure, yeah. We've also got a question about long-term uses of antibiotics for acne leading to IBS.
Yeah, it doesn't have to be long-term. Sometimes, Laura's commented that an infection seemed to trigger off her IBS, which is true of about 10 or 15% of people with IBS-like symptoms. A tummy bug will trigger it, but actually antibiotics can trigger it as well. And again, it probably is, of course, relates to the changes that antibiotics produce in the bugs that live inside us, and the slight sort of throwing up of the cards in the air and seeing what order they come back down in. And sometimes they'll come back down in the same order, and sometimes they'll come back down in a different order, which provokes the IBS.
Yeah. We just asking you, Miles, about you showed with some of the studies you've done. What more studies do you want to do? What do you see you're looking into going forward with this?
So I can see Juan is on the group here. Juan and I ran a study. Juan's one of my colleagues in the department here. Ran a study looking at the way that the FODMAP diet, the low FODMAP diet, interacts with the bugs in our gut, and we were able to identify a group of people who seemed to benefit rather more from the low FODMAP diet, which you could predict by looking at the bugs. Now, there's probably a bit more science to be done around that, but if we could get to a stage whereby we could alter the bugs inside us in a predictable way without having to put people on a low FODMAP diet, which is quite a tough diet actually, then that would be a good thing. And there are various people exploring how you might be able to do that. So yeah, I think that is an important direction of travel for these sorts of things. Understanding ever more about, I think, you know, insofar as we get a window, I think there is an interesting longer term study to do to understand what's the impact of the bugs on things like anxiety and depression and bipolar and so on. Is there a connection there? It seems likely to my mind that there probably is. And when people have looked at what we call the microbiota, this is just the bugs that live inside us, they are connected to a variety of medical conditions and indeed neurological conditions. And you know, we're all constantly being surprised by how these things influence all sorts of stuff that you feel at face value they shouldn't have any impact on that, but they do. And I think understanding a bit more about that would be, you know, both interesting and potentially valuable in terms of how we manage these conditions.
I'm bringing that back round to Laura and COVID, because Laura, COVID was where we sort of started out with this for you. Do we need to look into that? Is that something that's going to show up as a trigger for some of this, do we believe?
I think COVID has so many interactions with so many different things that it hasn't been around long enough. This is what I've spoken to kind of colleagues, obviously Miles as well. It hasn't been around long enough for us to understand a long-term impact. And I think that's probably, it's going to affect everybody in different ways, unfortunately. Miles, I know you've got some thoughts on COVID.
Yeah, as you say, Laura, it's a tricky, multi-headed beast, COVID, and understanding how that might impact on tummy abdominal symptoms is genuinely tricky, I think.
Mm-hmm. Yeah.
COVID wouldn't be completely unusual. We mentioned tummy bugs triggering off IBS. Sometimes flu or a bad cold will trigger it as well. So COVID is part of that, obviously part of that bracket of things that's just odd and difficult to explain, but which can do it.
Mm. And we've got a question here about the calprotectin test, a way of testing for IBS.
Yes, there isn't any single test for IBS. There are tests for other things, and a calprotectin is a test for inflammation in the gut. So when the GPs are testing for that, they're looking to see whether tummy symptoms are being caused by something like Crohn's disease or something like that. So that's what that's for.
Yeah.
And I saw the question below that about what about fecal transplants for IBS. People have used those. It won't surprise you to know. It's very unclear whether they're helpful or not at the moment, to be honest with you. There are some studies showing dramatic success with that, and there are other studies showing absolutely zero effect at all. And it won't surprise you to know there are some people out there charging an awful lot of money for you to have a fecal transplant done under their care. But be very careful. I would encourage you to not to rush off and do that, to be honest with you. there's not really good evidence that it works at the moment.
Someone's posted a question about aloe vera.
Yeah, give it a go. I mean, some of these things that are written in the, are in the ether, and which your granny would have told you about. Guess what? Some of them work. And I know some people swear by aloe vera. One of my neighbors does. And, give it a go. But like all of these things, a bit like probiotics, as I was saying earlier on, if after a couple of weeks on it, it's not working, then stop it. It's quite expensive, and don't keep going on stuff that's not working.
Yeah. So also something that, is possibly a little bit sensitive, but do you think there's a socioeconomic issue here? Is it because some people don't have access to good food or potentially access to exercise, perhaps? Do you think that has...
Yeah, I have to say, when we looked in our UK biobank study, there wasn't any obvious signal relating to socioeconomic factors. And indeed, if you look around the world, IBS is a world phenomenon. It really isn't just restricted to Western societies. So I think it's one of those unusual conditions where there isn't an obvious link to socio demographic factors, which is odd and interesting. There are other things which are more strongly linked to IBS than that.
Such as anxiety.
Yeah, that's a much more prominent signal.
Yeah, sure. So therefore, things like CBT, introduction of more availability of CBT to help people with anxiety, do you believe that would be beneficial? Yeah,
for sure it would. And of course, that is nowhere near as available as you would want it to be. And to be able to access CBT for management of IBS, really, unless you live in Manchester or parts of London, then it's just not available, unfortunately. It's not available around Cambridge, for example.
What was your experience of that, Laura?
It was actually never offered to me as a solution for management by my GP. It was only when Miles mentioned it, and it was just a coincidence that I was already under the management of a talking therapy anyway for my anxiety. The only thing that I had a thought of is, obviously CBT is very hard to come by in terms of the NHS, but there are factors such as the Headspace app that you can use that might be worthwhile giving it a go. It encourages meditation or kind of relaxation and things that obviously Miles has covered previously. That might be something to worth consider, because it's free or very low cost that is achievable for most people. So
sure. Yeah. Just moving on to eating disorders. That's something that we hear quite a lot about, and I believe that there's been certainly an increase in the prevalence of eating disorders during the pandemic. Miles, do you see some of that coming through to your work and to patients coming into you with that, where eating disorder is one of the causes or potentially one of the symptoms of this?
I mean, the eating disorders tend to be quite distinct, to be honest with you, to IBS, although there are, one does have to be aware, of course, that these things are prevalent, and to watch out that food fads have not sort of bled over into the sort of formal eating disorder types of things. But they tend to present rather differently, to be fair. Mm-hmm. I'm just having a look at the chat, and there's a few things coming through on the Facebook things, including from my old friend and colleague Kira Moore. Hi, Kira, nice to see you. Great to see you. Virtually, this information will really help inform clinicians or GPs across it. How might we get access to this for other systems? Yeah, it's a frustration, isn't it? That for such a common condition that, as Laura said at the beginning, it's so little talked about. And even if you go and see your GP, which is the natural route in, you don't always get a very consistent message. So, Juan and myself and others do spend a certain amount of time educating our GPs as to how to manage IBS, and they always love it, because this is such an enormous part of their workload that for them to have some really useful practical pointers about how to manage IBS, I think is useful. But there definitely is more work to be done there, actually. Mm-hmm.
And I see there's also a question here on taking
Amitriptyline, yeah.
Um,
Yeah. The thing about amitriptyline is you tend to have to stay on it rather than stopping and starting, because it can take quite a long time to work. So most people who are going to benefit from it need to stay on it, and it can take 2 or 3 months for it to really kick in. So people have to be patient with it. But it's not one of those things that you can just take when your symptoms are kicking off. That for things like Buscopan and high strength peppermint oil, those things you can do that with, but not amitriptyline.
Yeah, and there's a good question here about what should be routine assessment in primary care when there's a suspected diagnosis.
Yeah, so typically we just do some simple blood tests, and we make sure people haven't got the celiac blood test, and we make sure they're not anemic and there's no other signs of obvious inflammation. And a lot of the GPs do rely on the calprotectin test that was mentioned a minute ago. That's a reasonable thing to do, just to make sure that's not sky high. It's often a bit up, and not to overreact when it's just a bit up is an important part. But those sorts of basic tests, yes. If your GP is talking about doing CT scans or colonoscopies, unless there's good reason, then colonoscopy for somebody who's had tummy symptoms for 10 years or 15 years is not going to help at all, and it'll just make for an uncomfortable morning. So I'll be wary of that.
So we've got lots of questions still coming in, but we are running over time here.
Can I just pick off this one? Sorry, Adele, I've just seen it on the Facebook from Yvonne. Talking about urgency and needing to, being really limiting. Urgency is a dreadful symptom. It becomes more common in women as they get older. Sometimes women who have had given birth to children years and years before, of course. I'm afraid that some of those old obstetric injuries come home to roost. And this can be a real problem for people who have then got diarrhea on top of a weak anal sphincter. And, well, again, it's partly the concern about things as well as the reality about things. Now, using Imodium or loperamide, which you can just buy over the counter, is a perfectly reasonable thing to do in that situation. And to take that before you go out. Or the other thing is you can buy these things called Imodium instants that melt under the tongue, and they work in a couple of minutes. And they can be real lifesavers, partly because they work very quickly, but also just the psychological security of knowing that you've got those in your back pocket or in your handbag. That often just allows people to get out and about with confidence. And that's a really important thing, of course, for anybody who's struggling with bowel symptoms. Need to be careful you don't swing the other way and get bunged up and constipated, but using Imodium like that is totally fine, Yvonne. So I strongly encourage people to do that if that's an issue for them.
Thank you, thanks. So I am going to end the session here. We've got some questions here, but for those of you that we didn't get around to your questions, apologies for that. We've had a really good response this evening. And if we've been unable to answer your questions this evening, we'll try and put some of those back to you via email. There's going to be a recording of this webinar, and we're going to post this on the CUH website, so you will have an opportunity to just recap on some of the things that have been said this evening, because there's been quite a lot, I think, quite a lot of really useful things that we've learned. So I just want to say a really big thank you to our speakers, particularly to Laura, you joining us. Really great that you could do that. And Miles, thank you so much for sharing with us all the work that you've been doing here. And also a big thank you to you, Namu, for organising and facilitating this. I think it's been a really very good evening. So I wish you all the best and a very good evening to you all. Thank you very much.
Thanks, Adele. Thanks, Laura. Thank you, everybody.
Thank you. Bye now.